Hello again, everyone. I'm Ankita and I will be your moderator with Shivani. We are here today to unpack a question that sits very quietly at the heart of the work that we do here. We look at sexual and reproductive health and rights, but there's something that continues to remain unaddressed. Where does menstrual health truly fit into this conversation? For those of you who are new to Baala's work, we are a social impact organization based out of Delhi and Bombay, and we work across India as well as some pockets of Nepal and few countries in Africa. While our primary work includes focusing on eradication of period illiteracy and period poverty, we frame that within the larger framework of sexual and reproductive health rights. While our work started with looking at menstrual health and hygiene, what has continuously come up for us for the last 2 years is how important it is for us to look at this work within the larger frameworks of health and education, and how important it is to look at it from an integration lens. I'm going to talk to you briefly about how this came about in the way we started looking at menstruation at Bala. So, around 2 years back, we were working in this community, and during a needs assessment program, we realized that beyond menstrual health, there was a larger reproductive health crisis that was very, very visible in the community. So, there were multiple cases of anemia, miscarriages, teenage pregnancy, and each family had about 5 to 6 children. And we just started realizing that, how can we have conversations around menstrual health that focus also on these other challenges that are being faced in the community. So we started looking at menstrual health from a deeper lens, looking at the fertility window, looking at how to track it through the month to understand what is happening, and also to understand what is the intent of the community towards contraceptive usage, and how that is often missed because there's very limited knowledge about menstrual health as an overall life cycle sort of approach. So we soon realized that, a lot of the uninformed choices around sexual and reproductive health were also being made because menstrual health was sitting outside the purview of the larger framework. And this lack was often preventing them to make effective usage of contraceptive, not being able to diagnose their menstrual disorders very correctly, and how those were affecting fertility or their basic agency to plan a family. So, this allowed us to reflect more deeply on how we can look at menstrual health from a more agency and autonomy lens, and to be able to give the women in the community more awareness about making better decisions about their own bodies. So if you have a look at the UNFPA brief, which talks about MHHM and SRH integration, one of the 12 intersections around menstrual health and SRH is the topic, which is contraception, family planning, and menstrual health. We see that, in the global context, young girls continue to enter menarche without any understanding of what happens in menstruation, and that is leading to a lot of uninformed decision making, thus influencing their sexuality, bodily autonomy, and other health related decision making. So all of this and many more questions are at the heart and intent of this panel today, and we want to see how this integration can sort of unfold. Even some of the panelists today in this program, all of us were there together at the International Conference for Family Planning last year, and we were very visibly able to see this gap. In a 10-day event on sexual and reproductive health, we just had two panels on menstrual health. And this is what brings us back to the question, why this panel and why now? Because we felt that the sooner we realize the importance of integration of menstrual health within the larger framework of health and education, our fight against stigma and misinformation will be strengthened. So, in today's panel, we bring together diverse perspectives to interrogate this gap. We will explore what integration would look like in terms of practice, what has held us back, and what will help us move menstrual health from the peripheries to the center of sexual and reproductive health rights and justice framework. We do not want to say that, by talking about this, we do not want to crowd an agenda that already has many, many other issues associated with it. But we just want to see how can we make our current frameworks truly inclusive, and how can we address the challenges faced by people who are being left behind due to a lack of this integration. So before we move forward, I would like to introduce our expert panel with you today. Our first panelist is Dr. Varun Sharma. He's a social development professional with over 15 years of experience in research, monitoring, and evaluation, and policy analysis across public health, child rights, and social development. Currently working as a senior specialist for monitoring and evaluation at Population Foundation of India, he leads the design of evaluation frameworks, develops data dashboards, and conducts advanced analysis using large-scale national data sets. His work spans HIV/AIDS, tuberculosis, gender, child rights, reproductive and sexual health systems, as well as he focuses on linking data to program design and decision making. Welcome, Dr. Varun. Our next panelist is Emily Hopes, a technical advisor in the Contraceptive Research Development and Introduction Division at FHI 360, where she focuses on research utilization, knowledge exchange, and the integration of family planning with other global health fields, including menstrual health. With over a decade of experience in reproductive and menstrual health implementation and research globally, she specializes in convening cross-disciplinary stakeholders to advance evidence-based practices. Hopes leads a global community of practice dedicated to raising awareness and advancing research on contraceptive-induced menstrual changes, including menstruation-related non-contraceptive benefits. I welcome you, Emily. Our final panelist is Hamsa Vijayaraghavan, who serves as the Chief Operating Officer at MAP, a Delhi-based NGO working at the intersection of gender, access to justice, and migration. A lawyer by training, she leads strategy, partnerships, and programmatic work at MAP. With over 15 years of experience across humanitarian and development contexts, her work focuses on strengthening legal and policy responses for marginalized communities, including survivors of gender-based violence. She brings an intersectional feminist lens to issues of migration, SRHR, and structural exclusion. I welcome you, Hamsa, as well. We at Baala are extremely grateful to all the panelists for joining us today to talk about this very, very critical issue. And it's now my honor to introduce my co-moderator for this panel, Shivani Agarwal. Shivani is the implementation and research lead at Baala, a role that she's held since 2024, a human rights lawyer by training. She holds an LLM in human rights conflict and justice from SOAS University of London. She's a Felix Scholar and a United Nations Volunteers Awardee. Her work sits at the intersection of reproductive rights and business and human rights, with a strong focus on equity and access. Having presented youth voices across multiple global platforms, she brings policy insight and grassroots experiences to her work, bridging research, advocacy, and on-ground implementation. Over to you, Shivani.
Thank you, Ankita. A very warm welcome to all the panelists. The panel today seeks to interrogate how we can move beyond menstrual health as a service delivery framework to a rights-based architecture, which is grounded in dignity and autonomy. We aim to place rights not as abstract ideals, but as entitlements that place clear obligations on states and institutions to respect, protect, and fulfill. The continued framing of menstrual health as hygiene rather than rights depoliticizes the issue and shifts the responsibility onto individuals while also obscuring structural and institutional failure, where menstrual health stays fragmented onto different sectors like education, sanitation, or gender programming, instead of being recognized as central to sexual and reproductive health. So today I invite the panelists to interrogate questions of inclusion and accountability, including state responsibility, access to menstrual care products, policies addressing stigmatized and discriminatory practices, and intersecting inequalities being accounted for in laws and implementation. We aim to examine if the reason for this absence of menstrual health from SRHR is because of simply overlooking it or because the rights framework simply has not yet reckoned with the gendered, stigmatized nature of menstruation itself. Before starting, I'd like to remind the panelists that due to time crunch, we are allocating 5 minutes to each question per panelist. And I'll raise my hand at 4 minutes to let you know that you have a minute left. My first question is to Dr. Varun. Dr. Varun, in the beginning of the panel, Ankita spoke about how we started seeing more evidence emerge from our communities around the importance of this integration. You have been working a lot in the field and evidence from the field, both through your own work as well as during your work with PFI. specifically with the project titled Scoping for Expansion of Comprehensive Sexuality Education in India. In your learnings, were there any instances that emerged during the evaluation of the project that you found were particularly important evidence to help define the way menstrual health and sexual and reproductive health programs could be integrated?
Yeah, thank you, Shivani and Ankita, and good evening, everyone. Namaste. Yes, and I really want to thank Bala team for initiating this dialogue, on such a pertinent and timely topic. And I think Ankita and Shivani has already set a really good context for the discussion today that we are going to have. Now, coming to the question, yeah, definitely, that PFI has been working on this particular space since a long time. And if we talk about this particular project that's scoping for expansion of comprehensive sexuality education in India, so this project we implemented in four states: Uttar Pradesh, Delhi, Jharkhand, and Manipur. And our goal was very clear: to build political will for CSC integration in implementing states. And while implementing that one, so there were like different activities and activities we implemented. So I will just share three key insights from this project that definitely I think can speak directly to to today's discussion. The first insight was from our opinion analysis study, where we interviewed more than, I think, 150 stakeholders, including government officials in the states. And one thing that emerged very clearly from that opinion analysis study, that was like, particularly duty bearer government official, they were uncomfortable engaging with the word sexuality when we were talking about comprehensive sexuality education in the context of adolescent. So that because we need to implement the project in these particular states, so we made a deliberate shift that very time. We reframed the program as adolescent health and well-being. And that one particular change that has helped us a lot, and we secured that buy-in from seven government departments across states. Within this particular program, we also reviewed actually existing CSC curriculum across government and non-government sectors. And we noticed a consistent gap, that though curriculum existed, but there was no in-depth assessment that has measured at them against international standards. So that also helped us to build a case for CSC integration into government schemes, and that particular assessment was also acknowledged and included in UNESCO resources on CSC. The second insight was related to stakeholder concurrence. That when we talked to different stakeholders, we found that that no stakeholder said that menstrual health is not relevant. Everyone recognized that that it's a valid adolescent health concern. So that particular aspect is like really important lesson for program design. If if the stakeholders are ready to engage with the discussion on menstrual health, so that we should use it more deliberately as a starting point to broader sexual and reproductive health discussions, rather than treating it as a narrow hygiene issue and address it in isolation. So that was the second, that that we were having a stakeholder concurrence that they want to engage with the topic more frequently. The third learning that came from the same project was from Uttar Pradesh, where we also developed training content for teacher counselors, those who are managing Satya corners. In this in this particular training content, we brought together different topics, be it menstrual health, contraception, safe abortion, gender and violence, all in one framework, and that helped teacher to recognize that all these topics are interconnected, not separate. So, and those who were trained, they were begin to see that the interlinkages and interconnectedness between these different topics. And they also shared that that after the training, they were like more confident to create a more open space and non-judgmental space for their students and to address their queries. So that particular shift is also important in adolescent, apart from that content reaching to the adolescent. Lastly, though that project we conducted it, I think around 2022. But you know that our that engagement on menstrual health and hygiene is continuing through different to leveraging by leveraging our tech platforms. We have Educately, a platform where we provide that you can say that that self-paced online courses that are free and anyone can take that courses. And Urge for You is one course that is providing adolescent and gatekeepers, primarily teachers and other adults, accurate information on SRHN, including menstrual health. And when it comes to the other platform that we are using is Sneh AI. It is a AI powered chatbot that young people can use as a safe and judgment free space to ask questions about gender issues, menstrual health, and contraception, because these issues are not discussed in day to day or routine talks. So that is a very safe space they can engage with, and that provide accurate information, and also information that is primarily in their own language, because we know that youngsters, they don't understand, and they don't understand preaching language. So that's why we are using a interactive ways of sharing the information with them. So you see that I would like to stop with that. The menstrual health is not a secondary topic, it is foundation actually. And if we want SRH programs to be meaningful and effective, broader SRH program, then this foundation must be built early and built well. I will stop now and will be happy to take any question. I hope that I would have completed my points in the designated time.
Thank you so much, Dr. Varun. I think it's pretty fascinating to know that we have to many a times reframe the words around SRHR just to ensure there's more acceptance within the communities and within the larger space, despite recognizing the importance of this and despite, emerging evidence on this. But I guess we do what we've got to do. This brings me to another particularly vulnerable population whose issues specifically related to SRHR often remains neglected, which is the people in humanitarian context. Globally, 60% of preventable maternal deaths take place in humanitarian contexts, where deficiencies in infrastructure, security, and service delivery contribute to increased risks of unintended pregnancy and gender-based violence. Hamza, where menstrual health is still predominantly framed as a question of hygiene in the displaced and migrant context, it is closely intertwined with safety and exposure to harm. Limited access to sanitation facilities, privacy, and also menstrual resources can heighten this vulnerability to SGBV as well. From your perspective, how should we be rethinking menstrual health within SGBV prevention and response frameworks? Specifically, what would it mean to move beyond treating it as an auxiliary concern and instead integrate it into core protection strategies for displaced and migrant communities?
Thanks, Shivani. Thanks for having me as well. I think I just want to first thank you for the question, and I will get to it well within my time. But I think I just want to start off by also saying that I am, unlike the others on this panel, I'm not a person who is particularly conversant with this topic. As you know, again, it's an auxiliary topic for us, unfortunately, in the work that we do. I am a lawyer by training, and I very much stick to legal issues when it comes to my work as well. And we work primarily on access to justice, and the context that we work in is SGBV, not necessarily in a humanitarian setting, but mostly, at least in India and in Delhi, in a development/migration displacement setting as well. And I think part of the problem is that we look at it, we look at menstrual health again as a hygiene issue. And the program, I would not say there is not programming. I think if you treat the displaced population, especially where you're looking at a humanitarian context, in a context where there is a camp which is managed by an agency or a UN agency or an international agency, there tends to be more focus on menstrual hygiene. Again, it is largely the distribution of sanitary products or giving them information about menstrual health and hygiene. I think the problem with that is that it becomes, again, a scenario where you're shifting the responsibility onto the girls and the women to manage that. You're telling them how to take care of themselves, you're telling them what they need to know about their own bodies, and, to protect themselves. All of that is placing the burden on the person at the center of it, which to me, it's a little obvious, especially, I mean, this kind of programming started in the 70s and the 80s, when you didn't have the internet, when people didn't have access to basic information. People have access to information now. Everybody, even in those camps and in displacement settings, has a smartphone. People see advertisements, and menstrual health products are very freely advertised. So I won't say there's much, dispute there. So again, to me, that is the issue. And fundamentally, when it comes to menstrual health, in the broader context, it's not just, like you said, it's not a question of hygiene, it's a question of bodily autonomy. It's a question of how you see your own safety and your own protection in terms of how you are allowed to manage and control your body and everything that affects it. So it becomes a matter of, not just in the SGBV context, but even broadly in a much broader context, it becomes, a matter of dignity, which affects the way you engage with different systems, the way you engage with the education system, the way you engage with the labor, market, the way you engage with your employer. Because you asked a question specifically about displacement and migration context, I will say that the voices that you hear in discourse around menstrual health and hygiene are voices like ours. People who are aware that it is a branch of or a field of policy in whatever way, whether as health policy or as education or as whatever kind of policy. They are not the voices of the people who actually get excluded because of menstrual health related issues. So like we were discussing earlier, when it comes to the women in Beed in Maharashtra, there was a report very recently where they had to have hysterectomies because menstrual health was costing them. Well, this is not migrant labor, this is just labor. But these are women who are removing their uterus because, having a period for 3 days in a month costs them money, basically. It costs them days of, daily wages. And that's not a health issue. That is a severe human rights and policy issue. And I think part of the solution has to be in not just having, I mean, you need doctors and educators on this, because as Dr. Varun was saying, this is something that starts when you're 12 or 13 and you become aware of it. And that is when it starts affecting you, when you stop going to school because you're having your period for whatever, or you start getting excluded from the house because there is religious exclusion tied to menstruation, even today in our society. And this is not a problem in villages, this happens in cities. It can even happen in families like mine because it's so tied to being conservative or being religious or whatever, and caste for that matter. But when it comes to the displacement context, again, I have a minute left. I always speak too much. But I think the problem is not hearing certain voices, and in the displacement context, because they are already vulnerable and already excluded on so many other platforms, not giving them a chance to have access to menstrual health and hygiene means they automatically get excluded from labor markets, from education, from all of the other things. And it is a severe SGBV issue for the simple reason that because it is directly connected to bodily autonomy, it affects your sense of self and it affects your sense of what you perceive as a safety issue. And therefore, if you're not even able to talk about something that is happening to you every month, it's very hard for you to be able to talk about something that is, to be an aberration. And there is 10 times more stigma attached to an SGBV issue, even than there is to menstruation. So I think a lot of it is conditioning. And that is where the conditioning starts when you're 12 and 13 years old, when you're told that you're already weak and vulnerable and subject to somebody else's control. Therefore, that you have to take a step back when it comes to your own body. And I'll stop there. I probably did my 5 minutes. Thank you.
Thank you so much, Hamza. I completely agree. For girls and women to sort of have autonomy over their bodies, there must be inclusion practices across all sectors. Their awareness campaigns have to include more than just information. I also think that they should include different ways by which their bodies can be protected. For example, the UNFPA documents outlines that there's a deep and sort of bi-directional relationship between family planning and menstrual health. And it also emphasizes how menstrual experiences can influence contraceptive choices as well. And which brings me to Emily. Emily, a large section of your career has been working on contraceptives-induced menstrual changes, which is a side effect of contraception, which impacts millions of contraceptive users around the world. This work largely contributes by building integration suggestions for youth education, co-located delivery of menstrual health and family planning commodities, and stronger national practices. What would be your top three suggestions that can help bridge this gap between programs across menstrual and sexual and reproductive health?
Thank you so much for that question. And I also just want to say thank you for including me on this panel. Organizations and advocates from India have always been leading the way when it comes to menstrual health, so I'm really honored to be joining you all today. And I think your question is really important because despite really strong evidence that family planning and menstrual health are interconnected, most programs are still sort of designing and implementing these things separately. And that's a problem because people aren't served well by a system where they have to go to a different place or a different person for different issues. So it's really frustrating if you have to go to one place to get a family planning method and then a separate service provider to discuss maybe your heavy menstrual bleeding or your menstrual pain, and then to another place to talk about nutrition, especially because all of these things are interconnected and impact one another. So from the work we've done on family planning and menstrual health integration, and specifically, like you said, on contraceptive-induced menstrual changes, I'll highlight three key opportunities that I see. The first is to integrate counseling and education across programs. So one of the clearest findings from our research related to menstrual changes is that they're a primary driver of dissatisfaction and discontinuation of contraception, but they're often not even openly discussed during counseling sessions. So family planning clients don't expect or know that their bleeding or menstrual cycles will change when they use a contraceptive method, and this has real impacts on their lives. So it's critical that menstrual health is embedded in family planning education and counseling. So this means training providers to proactively discuss expected menstrual and bleeding changes during counseling sessions. We've actually developed a counseling tool that can be used to do this called the Normal tool, and I'll put that in the chat a little bit later. It also means equipping adolescents with a basic understanding of how contraception can affect their cycles, and this could be integrated into comprehensive sexuality education programs, like was discussed earlier. And then framing these changes as a part of a continuum that are normal, that need to be addressed by healthcare providers if they are impacting people's lives. And then the second is to move toward a more co-delivery system, like you mentioned, of menstrual health and family planning products and services together. So from a user perspective, the distinction between menstrual health and contraception doesn't really exist. It's just part of their lived experience. And so there's an opportunity to integrate services and practices on a few different levels. So providers could give clients menstrual products during family planning counseling sessions or refer clients to community-based menstrual health programs where they can access products and additional information. And then providers should be trained to identify family planning clients who may be living with menstrual disorders like endometriosis or heavy menstrual bleeding, and they should be counseled on methods that might help manage these pain and heavy bleeding symptoms. For example, the hormonal IUD is an approved method to manage heavy menstrual bleeding, but many people don't know that. But it can't stop there. It can't just be take this family planning method and you're good to go, because that's really frustrating for a lot of people. So they should also be referred to additional diagnostic and treatment services outside of contraception. And that should all happen within training of providers. And then the third thing is to create alignment at higher levels. So outside of the healthcare system, at levels like policy, funding structures, and measurement frameworks. So at the system level, one of the biggest barriers is that menstrual health and family planning, again, sit in different silos. And so they're never really together or integrated. So for example, menstrual health, as I think we've all mentioned, is often framed around hygiene, and it is often framed around reaching adolescent girls only. And then family planning is framed around fertility and it reaches women in their 20s and 30s. And so that leaves out a really large group of people. And so we need to integrate strategies more explicitly, like at the policy level, and then also develop shared indicators so that we're measuring the right things so that we understand the problem and can address it in an evidence-based way. So just measuring how menstrual experiences are impacted by contraceptive use. And then I think also crossed ministerial coordination is really important because often these things are in different ministries or in different parts of ministries, and so they need to be talking to one another. So ultimately, this is about shifting towards a more person-centered approach, and because people don't experience their health in silos. It's all one thing within a lived experience, and that's how the healthcare system and services should be designed to treat people. So if we better integrate these areas, we can improve not just access, but higher level things like satisfaction, continuation, and overall well-being. And I'll stop there. Thank you. I'll also put a few other resources in the chat for you related to this, so to take a look there.
Thank you, Emily. Encouraging everybody to take a look at the normal tone and other things that Emily shares. Emily, when you were talking about healthcare service providers to have more menstrual awareness in a way that it can be incorporated in their community-based programs, I started thinking about the frontline healthcare workers of India, which are the ASHA and Anganwadi workers. And in our many field visits, we have seen that not only is there a lack of awareness about SRHR and about menstrual health together. There's also like lack of access to products, and I want to talk about more worker integrated approaches, and that's why my next question is to Hamza. Hamza, according to the 2021 UNFPA brief on menstrual health and SRHR, one important area that emerges is menstrual health and workforce participation. It suggests that because there is limited data that exists on the impact of menstrual health at workplace, safety, because there's limited engagement, it can be pretty challenging, and women have to sometimes miss work also because of this. Your work revolves a lot around labor laws and rights. So while in formal sectors there we see some changes in policies. For example, there is maternity benefits acts, there is POSH, but there is a glaring absence of the same in informal sectors when approximately 90% of the working women in India are in informal and gig workforce. Why do you think such a gap exists, and what can be done about it?
I think why I think the gap exists is pretty straightforward. It goes to my previous point about whose voices tend to get heard. Um, and that is honestly, that is, it seems like a very oversimplified answer, but that is the answer because the people who make policy are also the people whose voices tend to be heard more. And they are the people who go into policy making. It's really, see, when it comes to any discourse around why there is a gap between policy and implementation, it is a discourse. Honestly, it's beyond this. And we can actually talk about it for years, like somebody said in the beginning. But I think it is a question of power and who has power to influence policy and discourse and what they are talking about. So when you're talking about labor, there are different kinds of labor. There is what we call white collar labor, and there is what we unfortunately call blue collar labor for whatever reasons. But I think labor policies are actually, so when you talk about the factories, people working in factories, that is not firstly made for women. That was not made at a time when women were working that much in factories. So when you want to integrate something like menstrual health and hygiene into, labor codes, that is very particular to modern times. Unfortunately, the imperative in that is, again, people run factories to make profit. They don't run factories to, support feminism or support women in the workforce. It's just that simple. So your emphasis, impact on your profit and your output, and that is the fact of it. So what that means is that the women who are actually working in agricultural fields or in any kind of heavy manual labor, construction, the policy is not made for them. The discourse around menstrual, you know in India is very limited to menstrual leave. And menstrual leave even in our organization, it is a stretch for us to be able to afford to give menstrual leave, because in the social sector, you don't have the cushion of, you're running a small organization with 10 people or 15 people, a lot of whom are women. So if you give menstrual leave in the way that policy would have you, somebody or the other would perpetually be on leave. Unfortunately, you just can't afford it. But yes, but we are able to make those, those arrangements. Whereas when it comes to where you are directly competing with men, it's the same as maternity benefits. I think maternity benefits has taken so many years to come to a point where it is at least institutionalized to the extent that even the smallest organized sector offices are able to and have to give it. But there is still a debate around, is 3 months necessary or 6 months necessary? Is 6 months too much? And I would say in that sense, we've gone further than, let's say, the US, where you don't have 6 months of maternity leave for whatever reason. I don't know what the compliance is, but the compliance, at least in urban centers, is quite high with the Maternity Benefits Act, but it's taken a while. When it comes to menstrual leave, it's still a policy debate, I would say. And it's largely influenced by corporate actors who want to do it as an employee welfare policy, which is a consideration in certain corporate settings where you also have to do, you have to have your PR, you have to comply, you have to be seen to be compliant, and more than compliant. Whereas in the construction sector, you're not compliant and no one is questioning you on it. There are no on-site checks to verify who is, in a condition to work, whether man or woman or for whatever reason. And I think that's why that gap persists, because fundamentally the people who, I mean, if there are women, honestly, if there are women who are getting hysterectomies voluntarily because they need the money for those 3 days, there is going to be a gap, right? You need to have more social securities in place so that you don't push people to take measures which are so violative of so many human rights tenets, just so they can make ends meet. I mean, it comes ultimately down to the kind of economy that you are and the amount of cushion that your people have within that economy for any kind of social security. And therefore, that is why menstrual leave and menstrual health has to very much be a part of social protection policy, not just a part of health policy. And even in health policy, I would go so far as to say that it gets lost within the larger SRHR health policy, blanket, which is all kinds of women's issues or women's health issues. Whereas it has implications beyond a lot of other, I think it would have the similar implications to what a Maternity Benefits Act would have, rather than to what just about any other women's health issue would have, which it is unfortunately seen as when it comes to policy.
Thank you so much, Hamza. I really want to talk about the 2 points that you majorly focused on, which was how important and essential it is to have the voices of the marginalized be a part of the changes that have to come in their own policies and how they are going to lead their lives, going to lead their careers. And also, thank you for bringing hysterectomies into the light of this conversation. Many a times, even because women and the families were not aware of any other methods, hysterectomy and permanent sterilization are very common methods for family planning as well. Which brings me to my question to Dr. Varun. Dr. Varun, in India, family planning programs and menstrual health programs often run in silos, where it's observed that family planning programs may not be completely successful as women are unable to make autonomous decisions of their own bodies. In your experience, has there been emergence of any evidence that shows that family planning programs can benefit with menstrual health awareness?
Yeah, absolutely, Shivani. That family planning program can definitely benefit from menstrual health and literacy. And these silos between menstrual health and family planning are not accidental, actually. They reflect on how these programs are designed and funded. And Emily also talked about that, and India is no exception. Menstrual health sits largely within school health and WASH framework, and family planning primarily sit in reproductive health and nutrition. Now the budgets are separate, implementing agencies are different, departments are different, and indicators that she also talked about that, indicators rarely speaks to each other. But the central idea is that, that the women or the girl at the center of both programs, be it menstrual health or family planning, is the same woman and girl. So how we can integrate these two, that is the real question, actually. And definitely, that there are published literature that has definitely talked about that, how that from menstrual health and literacy, family planning programs can be benefited. So let me just share a few statistics with you that that NFHS 5, that is the latest one available, though NFHS 6 is coming in few days only. So it talks about that that unmet need for family planning in India stand at 9% something. So in other words, that one in every 10 married women who want to avoid pregnancy, but they are not using any method. And within the married girls age 15 to 19, this figure is even high. When we look into the reasons behind these known use, the data point to that awareness gap, fear of side effects, and spousal and family oppositions, But when we deep dive into that, that what are the main reason, the qualitative studies and program evaluation provide us the root cause of non-use. And that shows that, that women who do not understand their menstrual cycle and those who do not have any framework to understand how their body work are less equipped to choose, use, or sustain a contraceptive method. So you see that how that knowledge gap and decision making gaps are interconnected. uh, I talked about that, that many published literature in international journals are there. We talked about, that women with with higher menstrual health literacy are more likely to discuss contraceptive with their husbands and health workers, and more likely to continue use a chosen method. Similarly, in areas where health workers talk about, that integrated counseling, they take an integrated counseling approach for menstrual health and family planning together. There, it is seen that, better contraceptive uptakes are seen in those areas. So, these are the findings from the published literature that highlight, that menstrual health awareness and literacy is a meaningful determinant and driver of family planning outcomes. I will share one more data point here that is also very important, and that will show that that how that menstrual health literacy is important for family planning outcomes. Again, from NFHS 2, actually, NFHS 5. In India, that only 62% current users of family plannings are ever told about side effects of those FP methods. So just imagine a woman with limited or no menstrual health literacy. She won't be able to distinguish, that what are the side effects and what are the symptoms. And with that limited understanding and or no understanding, she quietly discontinue family planning methods. So that's why here I think Emily also talked about, the counseling efforts, that how we should have integrated counseling for menstrual health and family planning, so that we can avoid these kind of dropouts. So these are the evidences in published literature and from national representative data, that how both family planning and menstrual health literacy is interconnected, and family planning can greatly benefit from menstrual literacy. Yeah.
Thank you, Dr. Varun. I think all of the data suggests that it is very critical to have a holistic approach to ensure that women build autonomy and are aware of both their rights and the options that they have. The Indian landscape is also developing policies around it, but these are currently focused, only on products and only on hygiene. Emily, in your advocacy efforts, you have often found focused on bringing family planning, menstrual health, and nutrition together. So, can you highlight how these three can be brought together for stronger menstrual health programming?
Sure, thank you so much for that question. So, in my previous answer, I sort of highlighted the way that family planning and menstrual health are interconnected and how they relate to one another, but we often don't think about nutrition and how that is also connected to family planning and menstrual health. And so I think that's also a really important piece to bring into the conversation and something that is not often talked about in the menstrual health space. I think the first thing we need to do is think about it in a life course perspective. So I mentioned this briefly in the previous question, but we need to think about how to holistically address menstrual health across the life course. So, for example, if we start with adolescence, they're not just managing menstruation, they're also navigating puberty. They're trying to get the nutrition that they need. They're trying to get the knowledge that they need related to both menstrual health, sexual and reproductive health, and nutrition. And as was mentioned, limited information and confidence can affect how they understand their bodies and whether and how they access both menstrual health and family planning services. And then, in addition to this, undernutrition and anemia can affect the timing of menarche and also cycle regularity and their menstrual experience overall. So, it's really important to address nutrition as well. And then for people in their 20s and 30s, menstrual experiences are often shaped by contraceptive use, like I mentioned before, with menstrual changes. And it's also a time when menstrual disorders are becoming really prominent or obvious, and people may be seeking answers and cares for menstrual disorders. And this can include through contraceptive use, and it should include that as well. And then perimenopausal women are people that we don't talk about at all during this conversation, and it's really, really important to address this group of women. Menstrual changes, again, intersect with broader health needs and are often overlooked in programming for this group. So contraceptives can actually be really useful for perimenopausal women in addition to hormonal therapy, and they actually sort of complement one another and help manage symptoms for perimenopause. But too often, this group of women suffers in silence and they don't get the help that they need. So rather than designing programs around a single issue, we need to design around people's lives and the stage of life that they're in. And then I know we've said it a lot of times on this webinar already, but we need to expand beyond hygiene. So we need to think beyond products and hygiene and facilities. Those are absolutely critical for menstrual health, but they don't capture everything that we need to be addressing. So I am going to say it again. We need to think about menstrual disorders and we need to think about menstrual pain because those are often problems that people rank as the highest issue that they have with their menstrual experience, but maybe the last or not even the thing that we address. And so these aren't just comfort issues, they're major health issues with real consequences in people's lives. And that can include anemia. So, anemia is a major public health concern globally and in India. And when it's left untreated, heavy menstrual bleeding can actually lead to anemia. And if you give someone iron supplements and change their diet, but they still have heavy menstrual bleeding, that doesn't change anything. They're still going to be anemic. And many healthcare providers and people don't know that this connection exists. And so, there's emerging evidence that shows that because of this connection, contraceptives can be a protective factor against anemia for women of reproductive age. And I'll put a few publications in the chat that sort of make this connection. There was actually one that just came out this month that looked at the National Family Health Survey in India, which was really interesting. So stronger programming should screen and manage menstrual disorders. And diagnosis needs to be timely because it often happens much later in life before things like anemia and other issues in life can be impacted. And so this really needs to happen early and as early as possible. And then third, this actually builds on my point earlier, but co-delivery of services needs to happen. And I mentioned family planning and menstrual health before, but it also needs to include issues of nutrition as well. That can happen in family planning, counseling sessions as well, referral to services, discussions about anemia and the connection to heavy menstrual bleeding. So I think that those are two very important things. Expanding our definition of menstrual health and approaching it in a life course perspective.
Thank you, Emily, for bringing both menarche and menopause into this conversation. There's also glaring evidence that stress and trauma, specifically in growing girls, can lead to unpredictable bleeding patterns, and most of which can be resolved by correct nutritional information and reaching the nutritional needs. I will now ask everybody an open question. Anybody can choose to answer. Please limit your answers to 2 to 3 minutes because of the time constraints. So we've already established that the current programs on family planning and initiatives in India do not account for the stigma that persists around menstrual health, that girls that limits girls' capacity to make better decisions on their sexual and reproductive health. But what would be your top two recommendations on how these two programs can be approached more comprehensively, both for adolescent boys and girls?
I can go first. Yeah, when I was also looking into this particular question and thinking about that, that whether that menstrual stigma is ever addressed in our national reports or not. So I was just doing a quick word search, regarding stigma in NFHS report. So that I could only found four counts of stigma word used in NFHS 5 report, and that was also used in the context of HIV/AIDS primarily. And to be frank, there was no single mention of menstrual stigma in NFHS report, although they do talk about menstrual protection, hygiene, and bathing practices. But specifically addressing these particular aspect in the national representative data is missing, and that is happening in all our monitoring and evaluation frameworks. That if we see HMIS data or SRS or even NFHS, I already talked about. So I believe that that my two recommendations will be like, one, definitely menstrual health and literacy should be formally positioned as an opening module, not like a hygiene sub component in any SRH program. It should be a full module or a full program within that particular purview, not like just hygiene related aspect we talk about and hush hush manner just complete it. The second one is definitely regarding that, that we should have a integrated monitoring indicators for this one, because what happened right now that both of these aspects, menstrual health aspects and family planning, they are entirely tracking different indicators. So that there should be some integrated indicator that could talk about menstrual health literacy as well as family planning. So just like that, that how many family clients were counseled on expected menstrual change before method initiation. Because right now that we do talk about counseling, but we are not talking about that pinpointing to that what was talked in that counseling. So these type of indicators can definitely help to make accountability real. And HMIS platform is like can easily accommodate this one, but that for that one we need a political and policy will also. So I will stop here and let the other panelists respond to their recommendations.
I'm happy to go next. So for this question, I wanted to highlight something that I and a few colleagues are trying to develop, which is this concept of menstrual agency. So what I mean by this is expanding our definition of menstrual health to include a lot of different things, but to include contraception as a menstrual health product. So I think that people should be able to choose the menstrual experience they want. Some people might want to free bleed and not use menstrual products at all. Some people might want to use a hormonal IUD to stop their bleeding or their pain because that's the experience they have. And then there's people who fall all along this spectrum. And the goal is that people have the information, options, and the environment around them to make this choice. So Hamza, you mentioned the example of women getting hysterectomies because they wanted to be able to work. And that is not a supportive environment for this menstrual agency to be realized. And so I think it's really important for the family planning community as we think about integrating menstrual health into programs. We can't just do this on our own. We need to turn to people who have expertise in menstrual stigma and human rights and ensure that we're doing it in the right way so that certain menstrual experiences aren't stigmatized further, because we don't want people to think that they can just stop their period and get rid of menstruation, and that would definitely stigmatize it further. So we really need to partner with people who have expertise, like advocates and human rights advocates as well. And then the second thing is, I would say, bring bring boys and men intentionally into the conversation. So family planning programs in some contexts have been really good at this, particularly engaging partners and couples when it comes to family planning counseling. So if we include menstrual health information and resources in family planning counseling, that could be a way to reach men and boys as well. So those are my two things that I would say. Thanks.
Thank you. I don't really have anything particularly, cerebral to add, but I'll say this. I think at some point we need to take this discourse, especially when it comes to policy and when it comes to bodily autonomy. It needs to be taken out of this whole. I know that family planning is a large umbrella, but I think what that does is it puts women into this role of being agents of reproduction. Okay? And I can say this much, no woman enjoys menstruation. So it's ridiculous to have stigma around something which you've been saddled with. Frankly, if I could not menstruate, I would not. And it's just that simple for me. I mean, I think it happens with a lot of things around SGPV, for example, stigma around sexual assault victims. And this is a pattern. The only way to fundamentally break that pattern is by educating men and boys and women, obviously, but men and boys, because they do still control the narrative, at least in our country and in most societies in the world, even today. But yeah, I will say this. Like I said, no woman enjoys menstruating. I have met women who enjoy being pregnant, and that is fundamentally because that's the only time they're not menstruating. So there you go. So I mean, let's not keep. I think somewhere we have to reinforce it as a women's rights issue because to me, the days that I'm having my period, I have to take leave. The day that if I'm like, it also goes to other. I mean, I'm breastfeeding my child. I'm fundamentally a less viable economic prospect for an employer. And there is going to be no equality in, the labor force. And there's going to be no equality in financial, discourse, whatever, like power between men and women, as long as you see women as disadvantaged because they are the ones carrying, the burden of reproduction. And yeah, I think at some point we have to stop just talking about it within this context of health and sanitation and family planning and women as wombs, that have to, go through this process every month and therefore they are weaker and therefore they are, they need leave and you're doing them a favor by giving them that leave. I think, yeah, we just have to change the way we talk about it. I mean, I hope it's not going to happen in my lifetime. But I do hope that in my daughter's lifetime, that you're seen as much of a person with agency and bodily autonomy as the next man. And because menstruation is the most frequent and regular reproductive process that every woman has to go through, I think that's where it has to start. That's the way to destigmatize it, just to normalize it.
Thank you, Hamza. There are 2 points that I want to talk about before I hand it over to Ankita to ask questions from registrations and chat. Firstly, given the days that we live in, there are so many cultures and taboos that further push stigmas around menstrual health management and around SRHR, which can lead to harmful practices. It is so shocking to know and accept that there's no acknowledgement of the same in databases like NFHS. And secondly, Hamza, to your point about female labor participation, I recently read a research by Claudia Golden, who is the first female economist to win a Nobel Award individually. And her research spoke about how when a country's GDP rises, the female labor force participation initially decreases. And the decrease over the years has only stopped after contraception was introduced. So until women had bodily autonomies, they did not even have the chance to participate in the economy because they were only looked at as people who would have no efficiency because they would not be a viable option as workers. Wrapping this up and sending it over to Ankita to take over the questions from chat and registration.
Thank you so much, Shivani. And I want to just thank all the panelists for such an insightful conversation. Like I was talking about before, some of the things that came up for us as well when we were starting to understand this space and this integration. I think one thing that came up very, very shockingly for us, considering that, we spent a large part of the work that we've been doing in Baala focusing on stigma associated awareness and then how to get more product access and things like that, was when we started talking briefly about how their experiences were associated with family planning in that particular community. And I think one important learning for us was when a lot of these women are in the second or third time that they have conceived and they visit hospitals, the doctors do not even seek consent before inserting a copper in their bodies. And that has often led to changing in the bleeding patterns, often led to, them not being able to understand what is now happening with their body, because they absolutely don't even know that there has been something that has been inserted in their body. And the reason that the doctors then present is that because there is no literacy and there is no understanding of what lack of family planning is doing to their bodies, we have no other option than to, do this without consent, because how else do you prevent miscarriages, or how else do you prevent anemia and cases like this? But I think to bring to Hamsa's point about, just thinking of women beyond their wombs and thinking of women from a rights and justice lens, it's so important for them to be able to get this understanding of what actually is happening in their bodies beyond health and hygiene, beyond the focus on, even in the family planning programs, how do we move beyond just the product lens and even within the MH space. So thank you so much for highlighting these things from these vast different spaces. And I think we had some very interesting questions that came up for us while we had sent out the registration form. So I would just like to speak a little bit about that. And I think anyone is open to sort of address them, but I think one question maybe I think would be very suitable for Varun, for you to respond to, would be there was someone who spoke about if the panelists could address how best menstrual health can be integrated into HIV prevention. Like you mentioned, even within the NHFS data, there is the mention of HIV is quite more pertinent. And also in the work that you've done in this space, I think within the integration spectrum of SRH and MH, there's something that can be spoken about from this lens also. So I think it'll be nice for us to hear a little bit on that.
Yeah, thank you, Ankita. Yeah, so, what I believe that when it comes to integration of menstrual health and HIV, or so to say, family planning also, the first and foremost important thing is to build the capacity of frontline workers. Only if they are equipped with that type of integration, they know that what are the benefits of integrating these two aspects. Then they can definitely provide the correct information to the community members. And when I'm talking about the frontline workers, that comes at the health providers also, not only ashas and asha sanganis, but ANMs, because when it comes to family planning aspect, that mostly now ANMs are uh, also inserting that IUCDs and all, and without the consent itself, and because they also have targets, and they just do, for the namesake, they do counseling, and they don't talk about that what are the side effects, and these are the manageable side effects and so forth. They don't talk about these things. So there is a need to build their capacity also, that for these integration, and we are doing that one in one of our project in UP, where we are building their capacity on that what are the different side effects and how that can be managed also, so that when they are conducting detailed counseling, at least they know what they are talking about. And so in HIV space also, I believe that that type of training is required for ICTC counselors, that how they can build information. That is my take, actually.
Thank you. I think that's very, very important for us to address, considering the amount of workload that goes on the frontline workers themselves, to be able to have that sort of sensitivity, I think is extremely important. And before I ask my next question, if anyone from the audience would like to pose any questions, please feel free to add your questions in the chat box. We do have some time to address those as well. Moving on to my next question, I think Kamsa, you may be suitable to respond to this, I think, but anyone can feel free to do that. Like we'd been talking about, how we need to go from a health, hygiene lens to a more fundamental right sort of, a justice sort of framework. Are there some recommendations that you would make, for example, focusing on, say, policy reforms or, any kind of accountability mechanisms that can be built to institutionalize menstrual health care across healthcare sector? And someone specifically asked this in the context of like marginalized and conflict regions, such as, say, the areas of Kashmir, places where conflict is much, much, much more higher. How do you sort of address, if there's anything you think that could be incorporated from a rights lens? Yeah.
So, like I said previously, in the conflict scenario specifically, I feel that when it comes to humanitarian assistance, which is very much a conflict scenario, feature, I think that again, menstrual health is something that is taken into consideration. Again, it is taken into consideration within the broader context of reproductive rights or reproductive health. I would not even say rights. And where there are resources, most of the humanitarian aid providers will have a program for menstrual health and hygiene, which is again around products. It's always around products. It's always around the distribution of sanitary supplies. So I wouldn't particularly have much to say about that in terms of policy, because I think because it's a controlled context in terms of having a set of people who are providing assistance, and these people are providing all different kinds of humanitarian aid. It includes food rations, it includes medicines, it also includes sanitary supplies. Because also, given that sanitation is poor in these spaces, there is more of a need to have more products being circulated. So I would say resources and programming provides for it. It is also the first thing to get cut out when resources run out, like we are seeing now. I like, there's no policy recommendation that I can make on that other than don't do that. It makes no sense, because women don't stop having their periods because funding runs out. But again, I'm coming from a space of some anger on this. But I think in general contexts, see, it just keeps going back. There is no accountability on this. Like, the problem is that there is too much accountability on women themselves to take care of their menstrual health, because it is seen as a hygiene issue. And the minute you brand something as hygiene is a personal issue. It's a personal hygiene issue. So obviously, if I'm the person doing the menstruating, I'm responsible for, using the right product, not offending anybody by menstruating without the product, disposing of the product properly, all of that. So that's what I meant. I think this is what I meant in my previous answer as well. Take it out of hygiene and health and put it into rights. And that has to be, it has to be integrated into policy discourse at the government level as well. And the minute you put it into rights, and it is women's rights, okay? It is not just women's rights, but it's okay, whoever is menstruating, basically. And that's more than half your population. And you need to put women, you need to put women in decision-making positions so that they have the experience to say this matters. Till something affects me, I'm not going to be able to. If I'm an officer sitting in the Ministry of Health or the Ministry of Women and Child Development, menstruation, there is no woman who's not going to resonate with what problems it causes her getting up and coming to work on a day when she's not feeling up to it, and why she has to apply for leave to a male supervisor to be able to do that. So I think the simplest way is to put it within the space of rights and policy, and not something that doctors and healthcare providers at the front lines have to manage, because these Asha Anganwadi workers that you're talking about also have the same struggle. And again, like, if you're putting it in adolescent learning curriculums, that is where you have to catch. Don't restrict it to girls. That's the first thing I would say. Like, my son needs to know about it as much as my daughter. It makes no sense, because all the people that he's living with this is affecting them, it's affecting him, it affects when he gets his dinner, when his mother is not feeling up to cooking it because she's menstruating. It's as simple as that. This is such an everyday basic thing that, I mean, it's unfortunate. It's really a comment on humanity that we've let it get this far, where we need to have organizations having policy discourse around it. But that is what it is. And I think what Emily said earlier about women in, again, menopause, or perimenopause, which it is the reason that they're not taken into account in these discussions is because they're past reproductive age. So the government is no longer concerned with, whether I'm adding to your population, I'm spoiling your birth rate dynamic. India has come to a birth rate of 2, apparently, which is under 2.1, which is your replacement rate, which obviously it's a big victory for the government. But at what cost? I mean, are we inserting family planning or contraception into, devices into women's bodies without asking them? Is that what we need to do? Is it not better to tell women what you're doing and how it's beneficial to them and get their consent? I mean, how are you going to make it a rights issue if you don't even acknowledge that women have the right to know what is happening to their own body? This is what, I mean, I'm not just the person producing a baby, right? It's, and then to look after that baby for the next 18 years. So yeah, I'll just stop there. Like I said, I come from a place of anger on these issues. I think more of us should actually.
I do agree that there is a lot of pain for a lot of us on this area, and with this, I think we're very close to coming to the end. I would like to take one question that has sort of come up in the chat, and I would like to put this to Emily. So you were talking about, how we can engage men and boys, and if you could make any recommendations specifically in the community context and in school context, from a policy lens, I think one important thing for us right now is with the new Supreme Court ruling that has come in India, which talks about menstrual health as a fundamental right. We do still see a lot of gaps there, specifically from an intersectional lens, specifically from an integration lens as well, because again, the focus is very, very adolescent girl centric. And of course, there are conversations on how that can become slightly more in the larger context of the school framework. But, if in any of your advocacy work or in the processes that you've been engaged in, if you see any recommendations that would be quite helpful in engaging boys and men, if you have any recommendations on that.
Yeah, I mean, I think it's a large thing to tackle. So I'm not sure if one thing is going to change it, but I think that I think it does need to start early because I agree that we need to make sure that men and boys at all ages know and understand menstruation. But if we start when they're younger in school, I think that's a good place to start, and then they continue to learn as they grow and interact with the people in their lives. So I think that starting early in school is really, really important. And then just finding any entry point and place where it might be possible to bring men and boys into the conversation will be really important. And I also think Hamsa's point about leaders is really important. I think women need to be leading, but we also need to educate the men who are in leadership positions about menstruation. And I think we need to be like a little bit creative in the way that we do that so that they really start to understand what women are going through. And so that menstruation and pregnancy and all of these experiences that we go through aren't seen as sort of in a negative light, aren't seen as something that impacts productivity or is something that is not good for society. We're the ones who are building society with menstruation and pregnancy. And so that should be looked as something that is sort of like a superpower that we can do this and that our bodies are going through this. And so I think that's really important also to educate male leaders.
Thank you so much, Emily. I think what we've also seen in some of the work that we were doing, especially in family units and with boys, we do see that, when we're approaching them around the age of 9 or 10, there is much more acceptance. Their thoughts are still forming around their own bodies, their peers, right? So when we talk to them about this, there's much more like acceptance, empathy, and as soon as the conditioning around masculinity starts, and the expectation from patriarchy and the gender norms that they observe in their own homes sort of kicks in, I think it gets harder and harder to sort of get them to be allies or even leaders speaking about this. So I think, I think Hamsa wanted to add something to this.
No, I just want to say, because you're talking about men and boys, I think it's important because, you know, we talk about when to bring men into the conversation. The problem is that they've been left out at all. I feel like, why are you having the conversation with girls in a separate room and boys in a separate room? They should be in the same room, because this is where embarrassment comes in. You know, like girls come out and titter about it, like, we learned this today. And boys are like, this is something that happens to you. They should be in the same room where they are able to ask questions, because so much of it, you know, all the stuff that we're talking about around pain and power and leadership is around empathy. You don't build empathy by putting them in two different boxes. You build empathy by putting them in the same room and allowing them to talk to each other about it. Like, I want my son to learn from my daughter's experience and to be empathetic to her. And it's just that simple. And I'm not just, you know, saying this from a place of privilege when I'm aware of, you know, this dynamic, and I'm aware of the patriarchy. All women are aware of the patriarchy. So I think it has to be that you do not make that distinction between boys and girls when you're giving out this information. You treat, yes, women are, you know, the people who are sort of driving that conversation because you have experience of it, and men are very much supposed to understand that experience and empathize with it, and not say, I mean, I think for too long the discourse around it has been, you know, even with more privileged men, it's like, oh, you're in a bad mood today. Are you PMSing? That's not a joke. Yes, I am PMSing, and I'm sorry you have to be the target of it, but you earned it because you don't even empathize and, I know, understand it enough to let me be. Why are you expecting me to be at 100% when I have an actual, like, if you have a cold, you know, or you hurt your ankle, I can be sympathetic to you. And that is exactly, it is a point where you need a little bit of extra care. Your body is going through a process. You know, there are also women in leadership positions who will tell you, you know, I never had any problem. I turned up to office till I was 9.5 weeks, 9.5 months pregnant, or I never took lucky. It's just luck. It's just luck. It's access to better nutrition. And I think you need to see it as a very basic, everyday conversation that boys need to be exposed to from a very young age. I would not even wait for adolescence, because by the time they're adolescent, there are, like Emily said, they're also dealing with puberty. There is, you know, boys and girls naturally segregate when they are 6 or 7 and start making for different reasons. I don't know if it's biological or conditioning, but there are many other factors at play. So I feel like you expose them to it and you talk about it in the same way that you talk to girls who are 8 years old now, because girls that are 8 year old are now beginning to have, you know, periods because of nutrition, hygiene, lifestyle, whatever it might be. I'm not the doctor, but I've seen it happening. And I feel like that is when you need to let boys be in the same room and see it, and make boys carry pads to school in case there's a girl who needs it. I don't see why women have to be going around handing out pads all the time to each other. It's so simple. If a boy has a cold, a girl will hand out a hanky, right? It's just that. Sorry, that went on.
Thank you, Hamsa. I think there are also people who resonate with your points in the chat, who've spoken about the impact of engaging men and boys from a young age and within the family setting and how that has proven out for them. And I think this brings me back to Dr. Varun's point on, you know, just the fact that in the Indian context, to be able to talk about comprehensive sexuality education, you need to remove the word sexuality and focus on adolescents' health is the biggest stigma that exists. So I think the biggest challenge for us right now is even to be able to have a conversation, to get a stakeholder to support your program, to fund your program. So I think there are so many issues that are focused around this entire area. And I think if we deep dive into this, we'll have so many important things to sort of pull out from these conversations. But I'm extremely thankful to all the panelists for making the time to come here today. And I think I would we do not have time to take any more questions, but please feel free to take these questions outside of this panel as well. We've put information about all the panelists in the chat box. Their LinkedIn details are also available. And in the coming weeks, we are going to put out some learnings from this panel on our social media also, so you can follow us and you'll be able to sort of have interactions there as well. I'm just now going to hand over to our co-founder, Aradhana Rai Gupta, to present a vote of thanks. Thank you, everyone.
Thank you so much, Ankita. I'll just take a few minutes. I know it's dinner time for most of us, so I won't talk too much, but just going to take a few minutes to thank our esteemed panelists. Hamza, I share your anger, and the emotion was felt by everyone in the audience. But thank you so much for engaging in this very insightful conversation, which spoke about integrating MH into the broader SRH rights systems. Emily, Hamza, Varun, thank you for your technical depth and also a lot of the implementation realities that you brought to the table. I think it helped move the conversation beyond awareness towards accountability, which is exactly what we were hoping today would be about. Thank you, Ankita, Shivani, Parul, everyone in the back end for hosting this and making sure that it all goes seamlessly. Thank you to the audience for sending in some very interesting questions that brought about a lot of emotions. At Baala, we hope that this is not the end of a discussion, but it continues towards a stronger and a more evidence-informed movement towards integrating MH into SRH in more meaningful ways. And that's why this is just the first part of a two-part series. Today was the online part. We also have a physical convening in Delhi on the 9th of June, where we will take the learnings from today, all the gaps that we've identified, to a larger group of practitioners, industry experts, researchers, doctors, funders, all working in this space. We really hope all of you can join us in that convening as well. We'll be sending the registration link out tomorrow to all of you. And I really hope to see you all there. Thank you again for your time, patience, and commitment to this work. Please enjoy your evening. Thank you.
Thank you.
Thank you, everyone. Bye.
Thank you.
Thank you.
Bye.